So this is the outline of my presentation: objectives, a reason for using postpartum family planning, benefit of postpartum family planning, potential side effects and complications, timing of insertion, counseling on postpartum IUD, women who are not eligible for postpartum IUD. The objectives are to articulate the reasons for using postpartum family planning, discuss the benefit of postpartum family planning, describe the potential side effects and complications of postpartum IUD, recognize the appropriate time of postpartum IUD insertion, identify women who are not eligible for postpartum IUD. Let me ask you a question. Why is postpartum family planning important? That can prevent unintended pregnancy and closely spaced pregnancies. There are various reasons for unintended pregnancy. The return of fertility is unpredictable during the postpartum period. Ovulation, the return of ovulation varies from woman to woman. So it can return within 3 to 4 weeks, even before the return of menses. Couples can resume sexual activity even before they plan for contraception. There is provider and client misconception about breastfeeding. Breastfeeding is considered as a contraception. So there is a confusion between breastfeeding and lactational amenorrhea method. When should contraception be provided during the postpartum period? So ideally it has to be provided before the risk of pregnancy returns after childbirth. During postpartum period, women are highly motivated to start using an effective method. So what are the benefits of postpartum family planning? So family planning by itself prevent maternal days by 30% and reduce child mortality by 10%. So if pregnancy occurs within 6 months after a live birth, there are adverse outcomes: abortion, either induced abortion and miscarriage, newborn deaths, preterm birth, stillborn and low birth weight, and high maternal risk of death. WHO recommended 3 health spacing of pregnancies. After a live birth, a woman should wait at least 2 years to get pregnant. After abortion, at least 6 months, and adolescents should delay pregnancy at least 18 years and beyond. So which methods of contraception can be provided for postpartum mother? So there are a range of contraceptions like long-acting reversible contraception, IUCD, and implant, permanent contraception, female sterilization, male sterilization, and barriers method and short-acting contraception can be provided for all women. For breastfeeding women, lactational amenorrhea method can be used until 6 months. Specifically, lactational amenorrhea method is a time-bound, and other hormonal contraceptive can be used. For non-breastfeeding women, progestin only method can be started just following delivery, and combined oral contraceptive pills can be given 6 months onwards for those who are breastfeeding, and 3 weeks onward for those who are non-breastfeeding, unless there is a risk of deep vein thrombosis. So most of the other type of contraception can be discussed on a series of lectures. I will concentrate on postpartum IUD insertion now onwards. So as to the timing of postpartum IUD insertion, there are two types: immediate postpartum period and early postpartum period. By immediate postpartum means it will be inserted within 10 minutes of delivery. So it is classified as either post-placental or intracaesarean. So this type of IUD has the highest rate of retention, meaning less expulsion rate. Early postpartum period can be inserted up to 48 hours after birth. There are 3 types of postpartum IUD insertion. The first one is post-placental, after the delivery of the placenta in a vaginal birth within 10 minutes. So it can be inserted before the woman leaves the delivery room. Intracaesarean is inserted after removal of the placenta during caesarean section. Early postpartum within 48 hours of the birth, preferably within 24 hours. So these are the types of IUCD insertion: post-placental, intracaesarean, and early postpartum. So there are certain limitations of postpartum IUD, and these limitations are minimal and they are almost similar to that of interval IUCD. One of the limitations is it doesn't protect against HIV or STI. Those women who are at high risk for HIV or other STIs has to use barrier method in addition to PPIUD. Since the length of uterus is longer as compared to the size of the IUCD and the string, usually the strings are not visible after insertion initially. Side effects: usually the side effects are minor. Commonly it causes changes in bleeding patterns. It causes menorrhagia, excessive menstruation, and excessive in amount and duration of menses, and dysmenorrhea, pain during menses. These two conditions are the common reasons for IUCD removal. Spotting, discomfort, and cramp. This usually occurs at the time of insertion and immediately following insertion, and usually self-limited. So spotting, discomfort during postpartum period may be considered as a normal part of recovery, and so it will be better tolerated than the interval IUD. Complications of postpartum IUD: uterine perforation. Since postpartum uterus is thick and uterine sound is not used during the insertion process, evidence showed that there is no reported case of perforation. Also, there is no significant effect on the risk of infection if the provider uses a standard infection prevention practice. Expulsion is higher than interval IUD, and immediate postpartum has lower risk of expulsion because it is possible to put IUD at the fundus, and the risk of expulsion is 5 to 8%, and the most expulsion occurs within the first 3 months. When can IUD not be inserted immediately postpartum? Meaning, what are the contraindications for postpartum IUD insertion? Prolonged rupture of membrane, 18 hours or longer, postpartum hemorrhage, sepsis during antepartum or following delivery, extensive genital trauma. Counseling for postpartum IUD, ideally it has to begin during antenatal care, and it has to be provided in phases. So during antenatal care, it can be provided as general health education, either in a group-based health education, and during this time, very basic contraception information can be provided. Individual counseling, then once a woman choose postpartum IUCD, method specific counseling can be provided, and once it is inserted, post-insertion counseling on danger sign of the danger signs and the need for follow-up has to be informed. There are different techniques for postpartum IUD insertion. Instrument can be used, long rigid instrument like Kelly or ring forceps, or manual insertion during intracaesarean, or as alternative for instrumental insertion. So let's have a case discussion. A 29 years old para to mother at gestational age 37 weeks gave birth to a male neonate by repeat caesarean section. She had a leakage of liquor an hour back. She had previous caesarean section. She wants to delay her next pregnancy for the next 3 years. What options of contraception do you counsel her? So she has 2 repeat caesarean section, and she can be provided with the most effective contraceptions like postpartum IUD or implants, and less effective contraception, hormonal contraception or barrier. What type of IUCD will you provide her if she opted for it? So she has 2 options, either intracaesarean postpartum IUD or interval IUCD following 4 weeks of delivery. As to conclusion, postpartum women are at high risk of unintended pregnancy. They have a range of contraception options to use. Postpartum IUD can be provided before they leave health facilities, and it can be inserted within 10 minutes or within 48 hours after delivery. And the risks of postpartum IUDs are low.